Today's topic is hyperlipidemia. I'm Allie Hoekstra, nurse practitioner student. Here's our learning objectives for today. We're going to talk briefly about the pathophysiology of hyperlipidemia, particularly as it relates to how your treatment options are chosen and how they work. We'll talk about options for treatment. We'll discuss the safety considerations of the treatment options within the context of the patient education. And throughout this presentation, we'll include the research-based evidence that has led to these recommendations. Cholesterol. It's a building block for cell membranes and proteins. The sources of cholesterol in the body are exogenous from the diet, as well as endogenous from the liver. Hyperlipidemia can be caused by conditions such as obesity, diabetes, and the other conditions you see listed here. It can also be caused by the drugs you see listed here. So treating hyperlipidemia may involve treating another condition primarily, or other conditions may affect your treatment choices for the hyperlipidemia. Cholesterol is carried through the body primarily on 3 of the lipoproteins. Very low density lipoproteins, which are produced in the liver, LDL or low density lipoproteins, which are the primary carriers of cholesterol, and high density lipoproteins, the HDL, which is essential for carrying cholesterol back to the liver to be excreted through the bile. In the diagram you can see over here on the right, I'm not going to talk through in detail, but it shows you some of these different components, but particularly the HDL leaning back into the liver. And these are important when we look at how the different treatment options work to impact the lipid cycles. And last but not least, there's triglycerides, which are what carry fat throughout the body. Managing hyperlipidemia is important because excess LDL produces more cholesterol, and if there's not sufficient HDL to carry that cholesterol back to the liver to be excreted, then atherosclerosis results. This impacts cardiovascular health. There are numerous studies that have been done around cardiovascular health that have shown that secondary prevention in patients who have cardiovascular disease is beneficial when it comes to hyperlipidemia. It both reduces mortality and reduces subsequent recurrent events. Primary prevention, the evidence is a little less conclusive. However, there are risk calculators to use in deciding whether or not to treat hyperlipidemia, and we're going to talk about those today. How does a patient with hyperlipidemia present? They will typically be asymptomatic. Now, with very high levels of lipids, you will have some physical evidence, and I've listed some of those here. These are prevalent in adults and children, and if they happen, then you should definitely include hyperlipidemia on your list of differential diagnoses. So screening guidelines. Patients with cardiovascular disease or diabetes should be screened for hyperlipid conditions. They have the highest risk for additional manifestations. Now, your patients without cardiovascular disease, there are different guidelines. Now, here's 2 very reputable sources. The American College of Cardiology, American Heart Association recommends screening from age 21. The U.S. Preventative Services Task Force has looked at the evidence and recommends screening from age 20 for patients who have risk factors such as diabetes, hypertension, but not until age 35 for patients with no risk factors. There are no recommendations for intervals of screening, although multiple resources have used 5 years as kind of a benchmark for how frequently you might screen your patients for lipid disorders. There is agreement about treating, in that part of your patient care should include a cardiovascular risk assessment for 10-year risk of, and there are multiple calculators that can be used for this. Again, the ACC-AHA calculator is fairly robust, but its critics say that it might indicate more risk than needs to be recognized. The Framingham 10-year calculator, on the other hand, doesn't take any stroke risk into account. So what this says to me is that evidence-based practice is important. Your evidence, your patient preferences, and your clinical judgment are going to come into play in how to manage these patients. I will add here that there is fairly consistent consensus that inflammatory markers should be included in your assessment of these patients. A CRP might be relevant to let you know whether or not they should be treated, and that's a consideration. Now, special populations, I want to say a few words here. Women have different cardiovascular risks than men, and the 10-year calculators will frequently show that women are falling below the 7.5% risk, which typically indicates they should be treated with a statin. But on the other hand, as well, women have been found, it's been found in women that low HDL is a more important indicator of cardiovascular risk than an elevated LDL. So these are some things to take into account when you're dealing with a particular patient. Older patients is another one. Over age 75, cholesterol does not appear to be an actual risk factor. Now, a patient over 75 with cardiovascular disease, a statin still benefits, but if they have no cardiovascular disease, a statin appears to show no benefit. And last, I've put African Americans and listed that here, but this applies to other ethnicities as well. Many of the studies do not reflect any ethnic information, and they may not have even included additional ethnicities for evaluation. So treating hyperlipidemia. First line is lifestyle changes, and these are very consistent with what you see for hypertension or cardiovascular disease. I will say that eating more fatty cold water fish because of the omega-3 and more soluble fiber in the diet on a daily basis are very essential to a cholesterol treating lifestyle change in diet. And we'll talk about this a little more and how beneficial it is. Treating hyperlipidemia with pharmacotherapy. In many patients, pharmacotherapy is warranted along with lifestyle changes. These are the examples. A patient who's diabetic and has an LDL of greater than 70. Any patient with an LDL greater than 190. So the first line pharmacotherapy is an HMG CoA reductase inhibitor or a statin. The primary goal is to lower the LDL first, unless they have high triglycerides. Then you need to look at starting with a triglyceride lowering agent or potentially using both, depending on the patient scenario. Now, the target is not always a specific number. The goal is to reduce cardiovascular risk. That being said, diabetics, the target tends to be to get them below 70. Others, it's to get their LDL below 100. But this last bullet point is important. You do need to continue to monitor, especially when a patient is making just notable progress in lowering their cholesterol, because too low of a cholesterol in LDL has been implicated in depression, anxiety, and memory loss. So, how do you choose the right statin? Well, here's the table from the ACC-AHA guidelines. And if you look at your indication down the side of the table on the left, let's look at the row 2, where a patient whose primary LDL is higher than 190. Look to the right for the treatment. We want to do a high-intensity statin with this patient. Let's look at the third line. Your patient's between 40 and 75. They have diabetes. Their LDL cholesterol is higher than 70. They're either going to be put on a moderate intensity statin or a high intensity statin if the cardiovascular risk calculator places them higher than a 7.5% on the risk scale. So that's a fairly straightforward treatment algorithm. Now here are your statins, your high intensity statins and your low intensity statins, and they block the enzyme to produce cholesterol. And I'm going to go ahead and interject here that all statins are not the same. If a patient doesn't respond well or doesn't tolerate a particular statin, say pravastatin, you should try them on another type of statin, a rosuvastatin or a simvastatin, before you abandon statin therapy. That's important to know. Now, let's look at some of the adjunctive therapy. Niacin used to be a first-line therapy for hyperlipidemia. However, it has some side effects, and a lot of people can't tolerate those side effects, a flushing sensation. 50 to 60% of the people being treated were the only ones who could tolerate it. However, niacin is very good at reducing triglycerides, and it can result in an appreciable increase in HDL. And there are some ways to counter the side effects with niacin, such as taking an aspirin 15 minutes prior to taking the niacin, spreading the niacin dose out, and taking taking it at 3 different times during the day with meals, for example. Another option is a fibrate. These also are very effective in bringing down triglyceride levels and have a somewhat variable effect on LDL and a moderate effect on raising HDL. They can't be used in anybody with severe renal disease, and they do have some adverse effects to consider. Now, bile acid binding resins work in the GI system, so they have no hepatic toxicity. They have a moderate good effect on the LDL, really don't affect HDL or triglycerides much, but because they're working in the digestive system, they can impact other digestive actions such as fat-soluble vitamins, other drugs that are absorbed in the intestine, and so on. Then we have ezetimibe, which also works primarily in the digestive system, has a moderate effect on LDL, and it's a good alternative if a patient is not a candidate for a statin or can't tolerate a statin. And then the omega-3 acids work primarily on the triglycerides. Their results on LDL and HDL are a lot more variable. And last but not least, we have a fairly new drug, the PCSK9 inhibitor, which is a monoclonal antibody, and it's shown to be very effective on reducing LDL. However, it requires a subcutaneous injection every 2 to 4 weeks, and it's not very cost effective at its current pricing. Now, another note about special populations is that in pregnancy, resins are the only safe medication to use. And then a note about combination therapy. There have been a fair number of studies on combination therapy, but they've had a lot of adverse events. So it's rarely indicated and would have to be managed very carefully. So let's talk about safety in the context of patient education. So One of the keys for patient education is that the lifestyle changes are just as important and work very closely with the pharmacological changes or pharmacological agents. Um, a good change in diet prescription, a dietary consult may be warranted, but can result in LDL reduction by as much as 30%. If the patient is going to be started on a pharmacological agent, particularly one that impacts the liver, the first-line statins, for example, then liver enzymes need to be assessed and monitored throughout the therapy. Some pharmacology may need to be titrated up to minimize the side effects. That's particularly relevant if you're going to put someone on a high-intensity statin. And again, as I said, if one statin isn't well tolerated, try another before you go to another line of therapy. Statins are taken once a day in the morning or the evening. The short half-life statins should be taken in the evening because cholesterol production is highest during the night. But there are statins with longer half-lives like atorvastatin that can be taken in the morning if that's going to be more effective for patient compliance with the therapy. Simvastatin and lovastatin do have a number of food and drug interactions, which are listed here. That needs to be considered and the patient needs to be aware, particularly if they're seeing multiple providers. Now, the most common side effects with statins are muscle aches and mild gastrointestinal effects. Again, if they don't tolerate one statin, try another before you move to a different therapy. Statins are associated with a 10% increase in the risk of diabetes. And there are some adverse effects that patients should be aware of and that they should be monitored for, including liver failure and muscle disease. There are over-the-counter medications that have been touted for hyperlipidemia. Red yeast rice is probably the most common. These are not regulated, so the production may vary from pill to pill, from bottle to bottle, and taking these supplements in conjunction with any prescribed therapy could definitely result in side effects and adverse events. Omega-3 found in nuts, for example, is very good from a dietary fiber standpoint, but it really doesn't lower triglycerides. Now, evidence for these treatment approaches. We've referenced some throughout the presentation. There are hundreds of studies on cholesterol-lowering agents, the dietary impacts of cholesterol. The Framingham Heart Study is a foundational study. But there are a lot of studies on the different drugs. There are numerous statin trials for different populations. I've listed a few here. One of the things to always bear in mind is that many of these studies are narrow in focus and they may not be generalizable to other genders, to other race, to other health status conditions. And here are the references that were used in today's presentation. Most of these are an easy read. And here's my contact information. If you have any questions or comments, I look forward to hearing from you.